Hello, everyone. Welcome to Chapter 9. So, today we're going to be talking about three significant chronic conditions that develop due to people having other chronic conditions. So, we've talked a lot about how a lot of these chronic conditions that we're seeing are you're likely not going to see them in isolation in an individual that you work with. So, yeah, here's three that the book highlights that often emerge due to people having the chronic conditions we've already talked about. So, the three that we will talk about today are depression as a comorbidity, lower limb amputation, and frailty. So, let's get started with depression first. So, half of all people with a chronic disease or disability experience depression as a comorbid condition. So, I mean, a lot of us have heard about depression. Maybe we've experienced it. It's not uncommon in even people who don't have chronic conditions. However, it is mentioned here specifically, and we actually will have a chapter near the end of the semester where we talk more about depression and anxiety disorders. So this will be a little bit more overview. We'll go more in depth for whatever week that lecture is scheduled for. But it's important here because it is a big roadblock for people complying with their prescribed treatment. So people who have depression are three times more likely to not adhere, and that can create a lot of complications for whatever chronic condition that they have. Also, the book notes that having an optimistic expectation is really important for compliance. So that is the danger with depression, among all the other things that come with having it. So, what is the pathophysiology of it? Well, we've heard it's something like a chemical imbalance, and that's, relatively what the issue is. So, there's an imbalance of serotonergic or endocrine pathways, or both, in the brain. And research is actually also saying that it's strongly associated with inflammation. And here's where exercise can come in handy. Inflammation and brain pathways can be modified by exercise. So, yeah, so some symptoms that people may experience, and maybe all of these, and maybe just a few, but we see profound sadness, fatigue, malaise, insomnia, self-degrading feelings, irritability, loss of appetite, involuntary weight changes, so on and so forth. There's more, of course, and it really depends on the person, and also it really depends on what condition that they have. Um, the factors that increase someone's risk of having depression is a family history of it, being female, and especially if they're postpartum, early childhood trauma, substance abuse, and then, of course, the whole theme of the semester, having a chronic condition or disability. Okay, so how do we manage it and what type of medications do they take? So, sometimes medication is given in isolation, and often if they are on medication, then they take it for several years. Or sometimes for some people, just, behavioral counseling or therapy works, and sometimes you combine both. So you'll take some type of medication and have therapy on the side. So that's typically the way that it gets treated. And now here's where we can come in. So can exercise also be, treated as a management plan for depression? Well, research suggests that the largest exercise-related antidepressant effects may stem from improving physical function. So, I mean, maybe I don't have to hammer this point home because of who's in our class, right? Like we all have some type of an interest in sports, physical activity. We've maybe done it our whole lives, but a lot of people you may work with may not know that, or maybe they know it and they just need some motivation to try it out, right? However, the optimal dose of how much exercise someone should do if they have depression is not known. So this is where we'll defer to some tips from the past. Use your judgment. You're gonna know your clients the best, right? So maybe consider what would, put them in that sweet spot of, okay, they're working out, they're getting good benefits from this, and it's not, they're not dreading it, right? So if you can find that balance, that would probably be ideal until research emerges and says what the optimal dose is. I've also listed a couple of different medications that people might take. Now, these are not all of the symptoms that these medications may cause, but it may be helpful for you to know. in case you are going to work with someone who's taking any of these. So, SSRIs are probably the most common medication that gets given, and it can cause an upset stomach, weight change, fatigue, dizziness, insomnia, and headaches. SNRIs have similar symptoms as SSRIs in addition to sweating, dry mouth, fast heart rate, and constipation. And then TCAs can cause changes in blood pressure and blood sugar levels. And then MAOIs can cause extreme hypertension. So, just like any condition we've talked about, knowing what medication your clients are taking would be extremely helpful for you. And again, we're talking about depression as a comorbidity. So, that means that they have another chronic condition, which they're probably taking medication for. So, yeah, definitely take note of that. So, how does depression affect the exercise response? Well, in general, again, whatever chronic condition they have, that's going to have an effect on the exercise response. But depression specifically, they may show an early volitional exhaustion, possible increased perceived exertion relative to their heart rate, peak exercise tolerance before below the maximum aerobic capacity, and then sleep issues, which accelerate physical and cognitive fatigue. So you may be looking at this list and you may think, you know what? I think I've gone through enough education and exercise science to know that exercise, regular exercise, can actually help with all of these. And you are right if you thought that. So the effect of exercise training, it may indirectly alleviate depressive symptoms by improving sleep integrity and the circadian sleep cycle. So that's great. Like we know all of the benefits that come with exercise, but this specifically may be really helpful for people suffering through depression. Um, and then there's also some research that indicates that there's an increased expression of brain growth factors, and that in turn influences chemical messengers in the brain that modulate depression and influence cognitive function. So just all, benefits all around, of course. So, what are some exercise programming recommendations? So, first off, depressive symptoms should be reviewed in all patients with chronic conditions. And then the main guideline here is actually dependent on whatever chronic condition that they have. So, if it's hypertension, if it's diabetes, if it's dyslipidemia, whatever it may be, that should be what guides the recommendations. Otherwise, yeah, they should gain a minimum of the CDD4 recommendations for exercise. That's kind of the baseline we work with anyway. And then there's also a note here that support from family and friends can facilitate their attempts to comply with treatment. So the main concern for you, probably if you work with someone who has depression as a comorbidity, is to get them to stick to the plan. And that doesn't mean not being um, flexible with them, right? But yeah, just, I mean, having support can also help with compliance. So yeah, that may be something you can recommend to them as well. Okay, now we're going to talk about lower limb amputations. So this may seem a little out of place because, we just talked about depression, which definitely develops in people who have chronic conditions. And then we have frailty, which also, comes about from chronic conditions. But here, lower limb amputation, you may be thinking, why is that kind of lumped in with these other two? Well, actually, it's associated with a very high risk of disability, loss of mobility, and short life expectancy due to cardiovascular disease. Um, Also, for this population, they need diligent effort to maintain mobility and independence, aggressive cardiovascular risk reduction, and good diabetes preventative care. Um, and then mobility and functional performance measures. This is where it's actually really important to work with these people. A vast majority of people who perform poorly on these measures will in 2 years be homebound, not ambulating with a prosthesis even at home, fully disabled, or possibly dead. So it does have a lot to do with the chronic conditions we've talked about. And in fact, why it has so much to do with it is that a majority of amputations are actually due to diabetes. So, um, so yeah, diabetes make up 2/3 to 3/4 of all amputations. I don't know if you guys knew that. I feel like you don't really, I don't know. I don't hear about that. I hear about it mostly from trauma or malignancies, but actually, diabetes and trauma together make up most amputations. Um, so diabetes, we have talked about that already, and we've talked about, that specific, I guess, downward spiral that they can enter. And so this is maybe one of the worst case scenarios that they can enter into. Um, and then trauma occurs mostly to younger, healthier people, and it's usually from something like a motor vehicle accident, especially motorcycle accidents. It could be from sports, which isn't as common as vehicle accidents, but it's possible. And then malignancy, that's usually like if they find cancer in the bone or something like that. And then birth defects, or if, yeah, they're just not born with it or amputate really early on in their life. However, most that you will encounter will likely be due to diabetes or trauma. But as noted here, there is a difference. So if they have gotten an amputation because of diabetes, then there's a really high chance that they're physically inactive. And I mean, I'm not going to list everything because we had the diabetes section already, but you can probably imagine that they have a lot of different comorbid conditions already and will likely not be very high functioning. So lower limb amputation will be a lot more serious for them to manage in order to keep their independence and their quality of life. Whereas for trauma, because it mostly happens to younger, healthier people, they actually can integrate into society a lot quicker and have a bit of an increased drive to learn how to use the prosthesis and get back into shape, right? So that, yeah, definitely depends on how it has happened and how your response will be for them. So there are different types of lower limb amputations. So here's just a list of them, right? There's minor amputation of just the toes, transmetatarsal or so-called cymes, leaving variable amounts of rear and midfoot, and then BKA, below the knee amputation, TKA, which is disarticulation at the knee, leaving the femur intact, AKA, above the knee, and then hip disarticulation. So it goes without saying that the higher up that the amputation is, the more high risk it is for that person to, you know, kind of be physically inactive, go about a sedentary lifestyle. So, I mean, that tracks because you're losing more joints, right? Um, so yeah, these are the types. And now, what's the management and the medication for lower limb amputation? Well, for diabetes patients, now usually if they have had an amputation, it's because there was vascular insufficiency. So, there were some issues with enough nutrients being delivered to that limb, and that's why they had to amputate. So that's a big concern. And then concerns that stem off of that is wound healing, residual infection due to the amputation, the quality of diabetes care, fitting of the prosthesis, and learning how to use it, and then emotional trauma of amputation. Um, and then there is this condition that, probably a lot of us have heard of already, phantom pain. So no matter what type of amputation that they've had, no matter for what reason, nearly everyone experiences phantom pain, where they're feeling pain in a limb that's not there anymore. So a lot of the medication that they take is actually just about managing this pain. So whether it's phantom pain or if it's from, something with the prosthesis fit, and so on. So yeah, that's mainly why they have drug therapy. So, what is the effect of this on exercise response? Well, the main thing is there's now body asymmetry, and the increased chronotropic response thereby increases RPE due to a 20 to 50% increase in cardiovascular demand. So, all that to say, things are not as efficient as they used to be with two legs. And then due to that, aerobic economy is lower, and then their rate of perceived exertion and heart rate response is higher. So in general, they're just not going to be as efficient as able-bodied clients that you may work with. So it's really recommended that they work with orthotists and prosthetists to ensure the prosthetic is appropriate for activity. Um, and there should be a really big focus on stump health and skin integrity. Okay, how can exercise help? Well, I mean, again, we're not going to list every single uh, benefit because we've talked about it, but they can expect all the benefits for hypertension and dyslipidemia, which, again, if amputation was for someone with diabetes or due to diabetes complications, they probably have one or two of these. Um, there's also an improvement in their ventilatory response and their ventilatory threshold, increased maximum oxygen consumption, and on average, it's been estimated that there's a 20% increase here, which is definitely noticeable. Increased heart rate variability is another thing. And then improved insulin sensitivity, which is all good stuff. So, what is the exercise programming and amputation recommendations? Well, the main goals for anyone, depending on, not important how the amputation was done or why, improve locomotion with the prosthesis. And this is especially important because if they either don't feel comfortable with it or if it's not a good fit, then they will likely succumb to sedentary behavior, and that's when that whole downward spiral starts, where ADLs are not getting done or not getting done as easily or efficiently. They become homebound, bedbound, so on and so forth. Like you guys will remember that spiral that we talked about at the beginning of the semester. So improving that so they can stay independent and be able to walk around is a big, big goal. And then, if possible, to increase the duration of physical activity to 150 minutes to 300 minutes per week. So, it goes without saying that if you're dealing with a younger person who had to have this amputation due to trauma, it'll probably be a lot easier to get them to this point compared to someone who had to have it amputated due to diabetes. Now, the guidelines are reflected in this. So, for traumatic amputation patients with few or no comorbid conditions, then ACSM guidelines are perfectly fine. There isn't really too much of a need to change this. And then if they had to get it amputated for cardiometabolic reasons and they have multiple comorbid conditions or they're just severely impaired in terms of physical functioning, then the CDD4 recommendations would be appropriate for them. Okay, now we'll talk about the last one, frailty. So this is a really complex phenomenon and it's actually not well understood. And similar to osteoporosis that we talked about maybe a week or two ago, it's a lot easier to delay or slow the onset of this than it is to reverse it after it has fully manifested. So catching this early is the goal here. And so there's five criteria as defined by Freed and colleagues in 2001. So weight loss, exhaustion, low grip strength, slow walking speed, and low physical activity. So these are the five like hallmark criteria that, can tell you if someone is approaching frailty or not. And thankfully, all of these can be tested, which we'll talk about shortly. So the problem with frailty is that, like many other conditions we've talked about, it has a really severe downward spiral if it isn't taken care of early on or if it isn't managed at all. So sarcopenia is the main reason for this, and that's the loss of muscle mass, um, and function. uh, get the distinction between muscle atrophy and sarcopenia. Atrophy, you may lose some muscle, but you can gain it back, whereas sarcopenia is a loss of function of the muscle, which you can't really get back. And then the other part of it is declines in testosterone and growth hormone levels. And what all of these lead to are an increased risk of falls, disability, cognitive decline, hospitalization, need for assistive living or nursing home admission, and then other conditions associated with physical inactivity. So, yeah, if we can catch these before it gets to this point, that is ideal. And again, similar to osteoporosis, if it already has manifested to a certain level, it's not really reversible. So yeah, it goes without saying, early detection is the best way to do this. There is medication that they take, but the book doesn't go too much into detail for this. So it just mentions that they can take growth hormone releasing hormone, or testosterone slash testosterone analogs. So that's mainly what they take to manage this. Also, data is inconclusive for the optimal therapeutic regimen for people who have frailty. So Yeah, not much is known about it, unfortunately. And hopefully more research comes out. So we've talked about early detection being an important part of preventing frailty. So the areas for assessment here that you can do to assess if someone's heading in that direction is first off, gait speed. So we've talked about gait speed before, because we've talked about, the different tests that we can do to assess it, and the slower that people do it, it usually determines, their outcomes. Um, so assessments to determine lower extremity strength and function would be really helpful here. And then balance, because we talked about a risk of fall. So assessments of balance and addressing their fear of falling is also a big one, which also, by the way, is why grip strength is one of the five criteria. Um, so that, the idea is, I mean, yeah, grip strength is very, very predictive for someone's long-term outcomes and physical functioning. And the idea is if you're going to start falling and you try to grab something, if you don't have great grip strength, then you might not be able to slow down your fall. So it has a bit to do with that. But some tests you can do for patients if you suspect that they're heading this direction or, have again other chronic conditions that are, leading them down this path, you could do a gait speed test, a chair stand test, and then timed walk tests. So how does this affect their exercise response? Well, I mean, there aren't too many specifics, but in general, they just have an inability to do much exercise, and that's primarily due to sarcopenia. And then they also just have weakness with low endurance and easy fatigability. So just you could kind of treat it as someone who's very deconditioned. So, what is the exercise programming recommendations here? Well, the main goal here is multimodal exercise programs that challenge multi-segmental motor control. And there has been research about strength training, balance training with this population, and it's proven to be helpful to them. So, yeah, choose multiple different modes, have them kind of vary what they do. That's ideal. There aren't specific things to really stay away from, I suppose. And the recommendations are also, what we've seen before. So the basic CDD4 prescription is good for them, emphasizing balance and strength because, again, balance, fear of fall, strength, it could be grip strength and gait speed. So, emphasizing those to keep their independence and their quality of life. Independent living is the most important. And then also encouraging proper hydration and protein intake. So, yeah, weight loss was one of the criteria, right? So, ensuring that they are eating enough, especially if they are exercising like this, just to see more benefits because of the exercise, that would be very helpful. All right, and that is what we have for chapter 9. Um, and yeah, so hopefully you enjoyed this series, chapter 8 and 9. And yeah, we'll be moving on after this to other specific chronic conditions.